All right, welcome back to part 2 of lecture 10. We're going to stay right in hematology mode and keep our focus where it belongs. What the red cells look like, why they look that way, and how that connects to what you'll see on a smear. This slide introduces thalassemia, which is one of the classic causes of microcytic anemia, but for a very different reason than iron deficiency. Thalassemia is a genetic defect affecting hemoglobin synthesis. Important distinction here, the hemoglobin molecules themselves are structurally normal. The issue is that the body cannot simply make enough of them. Think of it like this. You have a factory that builds perfectly good cars, but half the assembly line workers didn't show up. The cars aren't defective, there just aren't enough of them. Hemoglobin is built from protein chains. You have alpha chains and beta chains. If the defect affects alpha chains, then you get alpha thalassemia. If it affects the beta chains, then you get beta thalassemia. Both lead to the same downstream problem, insufficient hemoglobin inside the red blood cell. Because hemoglobin content is low, red blood cells are smaller than normal, MCV is decreased, and cells are more fragile. Many are destroyed prematurely, so you end up with decreased red blood cell production, increased red blood cell destruction, which explains why thalassemia behaves as both a production problem and a hemolytic problem. On a peripheral blood smear, thalassemia commonly shows microcystosis, which are small red cells, hyperchromia, increased central pallor, target cells, which is a classic finding, and marked anocytosis and poikilocytosis. Target cells happen because the cell membrane surface area is relatively normal, but hemoglobin volume inside is reduced, so the membrane collapses inward, creating that bullseye look. If you see lots of target cells and microcytosis, thalassemia should be on your radar. Because the bone marrow is constantly trying to compensate, bone marrow hyperplasia occurs, which can lead to bone deformities, especially in severe disease. Ongoing hemolysis and increased blood volume demands can result in splenomegaly, hypersplenism, congestive heart failure in severe cases. From a histology perspective, what matters most is chronic anemia, increased fetal hemoglobin, that's hemoglobin F in some forms, iron overload, which is often from repeated transfusions, not iron intake. An important lab pearl is that thalassemia is microcytic, but iron levels are usually normal or elevated. So iron supplementation does not fix the problem. Some worthless but fun knowledge is the name thalassemia comes from the Greek word thalassa, meaning sea, because it was first recognized in people from Mediterranean regions. So yes, this disease is literally named after the ocean. Big histology takeaway on this slide, when you're looking at blood smears, microcytic plus hypochromic does not always mean iron deficiency. Target cells plus very low MCV plus lots of variation equals think thalassemia. Your microscope will often tell you more than the lab values alone. Now let's talk about hypersplenism, which shows up frequently alongside many hypolytic anemias, especially thalassemia and hereditary red cell disorders. To understand this, we need to remember what the spleen actually does. Under normal conditions, the spleen acts like a quality control checkpoint for red blood cells, a filter that removes old red blood cells, damaged red blood cells, and misshapen or inflexible red blood cells. Red cells have to squeeze through extremely narrow splenic cords. If they're flexible, they pass. If they're stiff or abnormal, they get trapped and removed. Think of the spleen like airport security. Normal cells walk right through TSA. Suspicious-looking cells get pulled aside. In conditions such as thalassemia, hemoglobin content is abnormal or insufficient. Red blood cell membranes become unstable. Cells are often microcytic, fragile, and poorly deformable. Even though these cells may still function somewhat, the spleen says, yeah, you don't look right. So the spleen removes them early. Here's where hypersplenism develops. The spleen is constantly removing abnormal red blood cells. That workload increases dramatically. The spleen enlarges and becomes overactive. As it enlarges, it begins removing more red blood cells, sometimes platelets, and sometimes white blood cells, which worsens anemia instead of helping it. This creates a vicious cycle. So you have abnormal red blood cells, and you get splenic removal, which creates anemia, which creates increased red blood cell production, which creates more abnormal cells, and then more splenic destruction. From a histology standpoint, this is largely extravascular hemolysis. Destruction occurs primarily in the spleen, not within circulation. On blood smears, you may see increased reticulocytes, variable red blood cell shapes, evidence of chronic hemolysis. The spleen itself often shows congestion of red pulp, expansion due to increased phagocytic activity. Eventually, the spleen becomes so active that it contributes more to the anemia than the original disease. At that point, splenectomy may be considered. Removing the spleen does not fix the genetic defect, but it prolongs red blood cell lifespan and it reduces hemolysis as well as improves anemia severity. If you ever see a patient with chronic hemolytic anemia, an enlarged spleen, elevated reticulocyte count, you should immediately think hypersplenism is likely contributing. Some worthless but useful knowledge: the spleen normally removes red blood cells at about 120 days of age. In hypersplenism, red blood cells may only survive 20 to 40 days, sometimes even less, which explains why bone marrow becomes hypercellular. It's constantly trying to keep up. Just remember, hypersplenism is not a primary disease. It's a secondary accelerator of anemia. The spleen is doing its job, just doing it too well. Now let's move into hereditary spherocytosis, one of the classic membrane defect hemolytic anemias, and one that's very recognizable under the microscope. Hereditary spherocytosis is caused by a genetic defect in the red blood cell membrane. Most cases follow an autosomal dominant inheritance pattern, meaning only one abnormal gene copy is needed for the disease to appear. The defect involves membrane proteins such as spectrin, ankyrin, band3, and protein 4.2. These proteins normally form the internal scaffolding that helps red blood cells maintain their biconcave disc shape. When that cytoskeletal support is defective, portions of the membrane are lost over time, and surface area decreases and volume stays relatively the same. The result? The red blood cell becomes round instead of biconcave, hence the name spherocyte. On a peripheral blood smear, spherocytes appear as smaller appearing red cells, dense staining, and no central pallor. So remember, normal red blood cells equals donut shaped, a spherocyte equals meatball. No hole, no pale center. That loss of central pallor is one of your biggest microscopic clues. The biconcave disc shape isn't just for aesthetics. It provides flexibility, increased surface area, and the ability to squeeze through capillaries and splenic cords. Spherocytes lack that flexibility, so when they reach the spleen, they don't bend, they don't fold, and they get stuck. Because these cells are less deformable, abnormally shaped, the spleen identifies them as defective and removes them prematurely. This leads to extravascular hemolysis, shortened red blood cell lifespan, and chronic anemia. And over time, splenomegaly develops due to increased workload. The key manifestations include increased red blood cell fragility, chronic hemolytic anemia, splenomegaly, and elevated reticulocyte count. These patients are constantly trying to compensate by increasing red blood cell production in the bone marrow. Hereditary spherocytosis is one of the few conditions where you can often make a strong presumptive diagnosis from the blood smear alone. If you see numerous spherocytes, no central pallor, and evidence of hemolysis, you should immediately think membrane defect, not hemoglobin defect. Some worthless but useful knowledge: spherocytes are also seen in autoimmune hemolytic anemia, but HS equals inherited membrane problem, and AIHA is an antibody-mediated membrane damage. Different cause, same shape. That's why clinical correlation always matters. Big takeaway: hereditary spherocytosis is a structural membrane disorder producing rigid, spherical red blood cells that are selectively destroyed by the spleen. The red cells are fully hemoglobinized that just can't survive the obstacle course of splenic circulation. Now we're moving into G6PD deficiency, which is one of the most common enzyme-related hemolytic anemias worldwide, and a favorite when it comes to recognizable smear findings. Glucose 6-phosphate dehydrogenase is an enzyme that plays a critical role in protecting red blood cells from oxidative damage. Red blood cells don't have mitochondria. That means they rely almost entirely on this pathway to generate NADPH, which keeps glutathione in its reduced protective form. Think of it like this: G6PD equals the power generator, and ADPH equals the electricity. Glutathione is the fire extinguisher. No power, no extinguisher, we get oxidative fire. G6PD deficiency is X-linked recessive. That is why it is much more common and often more severe in males. Many individuals may carry the defect and never know it until they encounter oxidative stress. The anemia is episodic, not constant, so hemolysis occurs when affected individuals are exposed to oxidant stressors such as fava beans and oxidant drugs including antimalarials, sulfa drugs, nutrifurotone, or aspirin, especially in high doses. Without adequate G6PD activity, NADPH production drops, glutathione cannot neutralize oxidants, and hemoglobin becomes oxidized. Oxidized hemoglobin precipitates inside the cell, forming Heinz bodies. These are not visible on routine Wright-Giemsa stains. Special stains are required. However, the spleen can see them. As macrophages remove these inclusions, they literally bite chunks out of the red blood cell membrane. This produces bite cells and blister cells. These are classic peripheral smear findings in G6PD deficiency. On the smear, you may see bite cells, which have irregular membrane defects, blister cells, which are vacuole-like appearance, polychromasia from reticulocytosis, and evidence of hemolysis during acute episodes. Between episodes, the smear may appear almost completely normal. Most cells can handle oxidative stress. Red blood cells cannot. They lack nuclei, ribosomes, mitochondria, and protein synthesis capability. Once hemoglobin or membrane proteins are damaged, the red blood cell cannot repair itself. It's essentially a one-and-done cell. Oxidative injury leads to membrane damage, increased fragility, and intravascular and extravascular hemolysis. The bone marrow responds with increased erythropoietin stimulation, producing reticulocytosis and temporary compensation until the next exposure. So if you see bite cells, blister cells, sudden hemolysis after drug exposure, think enzyme defect, not membrane defect. That distinction is important. Worthless but fun knowledge: the geographic distribution of G6PD deficiency overlaps malaria endemic regions. Why? Because partial G6PD deficiency provides some protection against malaria, similar to sickle cell trait, nature's weird version of survival genetics. Just remember, G6PD deficiency is an enzyme deficiency causing vulnerability to oxidative stress, leading to episodic hemolysis with characteristic smear findings during attacks. The red blood cell itself is structurally normal until oxidative stress exposes its weakness. Now we're shifting into a form of hemolytic anemia that is not caused by a problem within the red blood cell itself, but rather by the environment the red blood cell is forced to travel through. In other words, the red cells are innocent bystanders. Let's break the word down. Micro equals small, angio equals blood vessel, and pathic equals disease. So microangiopathic hemolytic anemia is red blood cell destruction caused by disease of small blood vessels. The cells aren't defective, the roads they're traveling on are. This anemia is caused by rough or abnormal surfaces within the bloodstream, including prosthetic heart valves, atherosclerotic plaques, and disseminated intravascular coagulation, or DIC. These surfaces act like microscopic cheese graters. As red blood cells squeeze through capillaries and small vessels, they are torn, shredded, and fragmented. No immune system involvement needed, pure mechanical trauma. As red blood cells pass through these damaged vessels, membranes rupture, cytoplasm is lost, and cells fragment into pieces. This produces one of the most important smear findings in hematology, schistiocytes, also called helmet cells, red blood cell fragments. These are diagnostic clues you should always recognize on a peripheral smear. On the smear, you may observe schistiocytes, which are irregular, jagged fragments, spherocytes from membrane loss, and polychromasia from reticulocytosis. Also increased ansiocytosis and poikilocytosis. The image on the slide shows multiple classic examples of fragmented red cells. If you see sharp angles, think trauma, not genetics. Because red blood cell destruction is rapid, the body compensates aggressively. This results in increased erythropoietin, hyperplasia of erythroid precursor cells, and elevated reticulocyte count. So the bone marrow is working overtime trying to keep up. Think of it as a factory on double shift trying to replace products being destroyed faster than usual. This anemia is normocytic, normochromic. Why? Because the red blood cells are produced normally, they're just destroyed prematurely. The problem is not size or hemoglobin content, it's survival time. Microangiopathic hemolytic anemia is commonly associated with DIC, mechanical heart valves, and severe vascular disease. But histologically, your biggest clue is always the same: fragmented red blood cells on the smear. So in histology, if you see schistiocytes, red blood cell fragments, and reticulocytes, ask yourself, is something physically damaging these cells? If the answer is yes, think microangiopathic hemolytic anemia. A fun but useful knowledge is that schistiocytes are one of the few red blood cell morphologies that should immediately raise concern when seen in significant numbers. Even a small increase can be clinically meaningful. They're not subtle, and they're never normal. Microangiopathic hemolytic anemia is caused by mechanical destruction, occurs within small blood vessels, produces red blood cell fragments, and triggers strong bone marrow compensation. The red cells themselves are normal, the bloodstream is not. Up to this point, we focus mostly on anemias where red blood cells are being lost or destroyed. Now we shift gears to an entirely different problem. The bone marrow simply isn't making enough red blood cells. This is a production issue, not a destruction issue. Under healthy conditions, the bone marrow is constantly producing red blood cells through erythropoiesis, regulated primarily by erythropoietin, or EPO, from the kidneys. Think of erythropoietin as the factory supervisor. If the signal is strong, production increases. If the signal is weak or missing, production slows. In these anemias, bone marrow red blood cell production is inadequate. Reticulocyte counts are typically low or inappropriately normal. That low retic count is a big histologic clue. If the marrow isn't responding, something upstream is wrong. Red blood cell production requires several essential building blocks. If one of these is missing, erythropoiesis stalls. The major ones include iron, folic acid, and vitamin B12. Think of red blood cell production like baking cookies. You can have the oven, just the marrow, fully working, but if you're missing flour, sugar, or eggs, no cookies happen. Depending on which nutrient is missing, the peripheral smear looks very different. So iron deficiency, we'll see microcytic, hypochromic red blood cells, increased central pallor, and pencil cells may appear. On folate or B12 deficiency, we'll see macrocytic red blood cells, oval macrocytes, and possible hypersegmented neutrophils. Same problem category, completely different morphology. This is why morphology matters. Another major cause of decreased red blood cell production is low erythropoietin levels, seen commonly in severe chronic infections, chronic inflammatory disease, and chronic kidney failure. In kidney disease, the marrow isn't damaged, it just isn't being told to work. So no EPO signal equals low red blood cell output. Histologically, the marrow may show decreased erythroid precursors, overall hypocellularity, or normal cellularity with poor erythroid maturation. Again, the factory exists, production is slowed. Red blood cell production can also be impaired by drugs like chemotherapy or some antibiotics, environmental toxins, or radiation. Marrow replacement by fibrosis, which is scar tissue, malignancy, or metastatic disease. When marrow space is replaced, there is literally nowhere left to make red cells. So in histology, when you see anemia with low reticulocytes, few immature red blood cells, or reduced marrow response, always think this is a production problem, not loss, not hemolysis, just not enough cells being made. So big picture, anemia with decreased red blood cell production results from lack of essential nutrients, lack of erythropoietin, and the bone marrow suppression or replacement. The red blood cells that are produced may be normal. There just isn't enough of them. So worthless but fun knowledge, red blood cells are produced at a rate of about 2 million per second, which means even a small disruption in marrow function shows up very quickly on lab work and on your histology slides. Iron deficiency anemia is the most common nutritional deficiency worldwide, which means that it is not rare, exotic, or mysterious. It's the bread and butter anemia you will see over and over again. If anemia had a most likely to appear on a peripheral smear award, this one would win every year. Iron is essential for one critical reason. You cannot make hemoglobin without it. About 80% of all iron in the human body is locked inside red blood cell hemoglobin. So when iron is low, hemoglobin production drops, even if the bone marrow is otherwise healthy. Think of iron as the red pigment cartridge in a printer. The printer works, the paper is loaded, the software is fine, but without ink, everything prints pale. When iron levels fall, the marrow keeps producing red blood cells, but each cell gets less hemoglobin. Instead of making fewer cells, the marrow makes smaller cells and with less color. That's why iron deficiency anemia is classified as microcytic hypochromic anemia. So microcytic equals small cells, hypochromic equals pale cells. On the peripheral smear, this anemia practically announces itself. You'll see red blood cells that are smaller than normal, increased central pallor, and thin, pale red cells. Possibly anisocytosis, which is size variation, or possible poikilocytosis, which is shape variation. In advanced cases, you may even see pencil cells or elongated oval red blood cells. These smears look tired, and frankly, the cells are tired. On the left, you see normal. Red blood cells are uniform. Central pallor is about 1/3 of the diameter. Nice hemoglobin density. On the right is iron deficiency. Red blood cells are noticeably smaller. The pallor takes up most of the cell, and some cells look like pink Cheerios. If the red cell looks like it forgot to finish developing, you're probably looking at iron deficiency. So typically is seen with low hemoglobin, low hematocrit, low MCV, and low MCHV, and increased RDW because cells vary in size. Histologically, the smear often tells the story before the numbers do. So even though this diagnosis is made clinically, your slide quality still matters. Thin areas exaggerate pallor, thick areas hide hypochromia. So a well-cut, properly stained smear is essential for recognizing these features accurately. This is one of those conditions where histology absolutely supports diagnosis. Normal red blood cells are like full water balloons. They're round, plump, and flexible. Iron deficient red blood cells are like half-filled balloons. They're smaller and floppier, and they're less efficient at doing their job. They still circulate, just poorly. Your body contains about 3 to 4 grams of iron total. That's roughly the weight of one small paper clip. Lose a little of it, and your entire oxygen delivery system starts malfunctioning. So key histology takeaway, when you see small red blood cells, very pale centers, and increased variation in size, overall washed out appearance, your histology brain should immediately think iron deficiency anemia. This is one of the most visually recognizable anemias you'll ever see. Okay. So we've talked about anemias caused by blood loss and red cell destruction. Now we shift gears to a different problem entirely. The bone marrow simply isn't making enough functional red blood cells. And when the marrow struggles, the microscope tells the story very clearly. So megaloblastic anemia occurs when there is a deficiency of vitamin B12, folic acid, and both of these vitamins are absolutely required for DNA synthesis. And here's the key concept. Hemoglobin synthesis continues, but DNA replication does not. So the cell keeps growing. but it can't divide on schedule. When nuclear maturation lags behind cytoplasmic growth, we get large red blood cell precursors in bone marrow, abnormally large circulating red cells. These are the classic macrocytes. On peripheral smear, you'll see large oval red blood cells, increased MCV, and often hypersegmented neutrophils. That neutrophil with 6 or more nuclear lobes, that's your megaloblastic red flag waving. Think of red blood cell development like baking cookies. The cytoplasm keeps adding ingredients and growing, but the oven timer for your cell division never goes off. So instead of normal-sized cookies, you end up with giant, misshapen cookies that never finished correctly. They circulate, but they're inefficient and fragile. These deficiencies can occur due to inadequate dietary intake, malabsorption in the intestine, or increased metabolic demand. But histologically, B12 and folate deficiency look nearly identical. The microscope doesn't care why, it just shows you the result. And then we have pernicious anemia. Pernicious anemia is a specific type of vitamin 12 deficiency. This one is not about diet, it's an autoimmune disease. Autoantibodies target gastric parietal cells and an intrinsic factor. Without intrinsic factor, vitamin B12 cannot be absorbed in the ileum. So even if the patient eats plenty of B12, it never makes it into circulation. So the result is severe B12 deficiency and an impaired DNA synthesis, as well as macrocytic anemia. And again, the smear shows it beautifully. On peripheral smear, we'll see abnormally large red blood cells, oval macrocytes, and normal or slightly increased hemoglobin concentration, as well as hypersegmented neutrophils, and an overall crowded but inefficient appearance. These cells look impressive but function poorly. Big does not mean good. In iron deficiency, we'll see small cells, pale cells, microcytic hypochromic. In megaloblastic anemia, we'll see large cells, adequate color, and macrocytic anemia. Opposite problems, opposite appearances, but the same outcome, decreased oxygen delivery. Vitamin B12 stores in the liver can last 3 to 5 years. So when B12 deficiency shows up, the problem has usually been brewing for a long time. Your microscope is basically diagnosing someone's nutritional history. So key takeaway, when you see very large red blood cells, oval shapes, hypersegmented neutrophils, and elevated MCV, your histology brain should immediately think megaloblastic anemia due to B12 or folate deficiency. And if intrinsic factor is missing, then we think pernicious anemia. This one is sneaky and extremely common. Anemia of chronic disease is actually the most common anemia in the United States. Not because patients don't have iron, but because the body refuses to use it. This anemia is not caused by blood loss and not caused by iron deficiency. It's caused by chronic inflammation. When inflammation hangs around long term, the body shifts into survival mode and says, let's lock everything down. Unfortunately, that includes iron. Anemia of chronic disease is seen in patients with cancer, chronic inflammatory diseases such as rheumatoid arthritis, chronic infections, and chronic renal disease. Basically anything that keeps the immune system activated for months or years. Inflammation activates immune cells, especially macrophages and T cells. These release inflammatory cytokines like IL-6 and TNF-alpha, IL-1, and IL-6 is the real troublemaker here. IL-6 results in hepcidin increase. Inflammation causes the liver to increase production of hepcidin. Hepcidin is the hormone that controls iron traffic. And when hepcidin increases, iron is trapped inside macrophages. Iron cannot exit storage sites. Therefore, iron cannot bind transferrin. Iron cannot reach bone marrow. So even though iron is present, it's biologically unavailable. Think of iron like packages at a warehouse. The iron exists, the shelves are full, but hepcidin locks the loading dock doors. No deliveries leave the building. Bone marrow is standing outside yelling, hey, we need iron over here. And the liver says, nope, inflammation rules. From the marrow's perspective, iron is low, erythropoietin response is blunted, red blood cell precursor proliferation decreases, and even though total body iron may be normal or high. This is why iron therapy usually does not help. The problem is regulation, not supply. Peripheral blood smears typically show normocytic, normochromic anemia, sometimes mildly microcytic. We see a decreased red blood cell count, normal morphology overall, no dramatic shape changes. So translation, the cells don't look terrible, there are just not enough of them. Compare this to iron deficiency anemia. In iron deficient anemia, we see low iron, low ferritin, microcytic, hypochromic, and the bone marrow wants iron but can't find it. Anemia of chronic disease, we see normal or increased ferritin, iron trapped in macrophages, iron present but not available, and the bone marrow is being ignored. Same lab symptom, but different pathology. Given iron doesn't help much because hepcidin blocks absorption, hepcidin blocks iron release, and inflammation continues the cycle. Until the underlying disease improves, the anemia will persist. So histology, when you see mild anemia, normal looking red blood cells, patient with cancer, inflammation, autoimmune disease, or kidney failure, think anemia of chronic disease. It's not flashy on the slide, but it's extremely important clinically and histologically. Some worthless but useful knowledge, ferritin is an acute phase reactant. So in chronic inflammation, ferritin can be normal or elevated even when functional iron is low, which makes lab interpretation extra annoying. Histology, once again, helps explain the chaos. So big picture summary, most common anemia in the United States is caused by chronic inflammation. Iron is present but locked away. Hepcidin is the villain. Normocytic, sometimes microcytic, and a poor response to iron therapy. It is all about real estate, specifically. What happens when something moves into the bone marrow and pushes the normal hematopoietic cells out? So myelophysicic anemia occurs when normal bone marrow is replaced by something that does not belong there. That something is most often malignancy or fibrosis. So instead of nice, organized marrow producing blood cells, we get a crowded, dysfunctional mess. And there is primary versus secondary. So primary myelofibrosis is bone marrow fibrosis of unknown cause. It's rare and progressive, and unfortunately no truly effective treatment. Histologically, you see dense fibrous tissue, markedly reduced normal marrow elements, and disrupted marrow architecture. This is not a subtle change under the microscope. The most common cause is metastatic cancer, especially to the bone marrow. Common offenders include breast cancer, prostate cancer, also lung, kidney, and GI tumors. These tumor cells migrate to the marrow and set up shop where hematopoiesis should be happening. On bone marrow biopsy, you may see sheets or clusters of malignant epithelial cells, replacement of fat spaces, compression of normal hemopoietic cells, increased fibrosis. So essentially, the marrow scaffold is still there, but the tenants have been evicted. Think of bone marrow like a factory. Normally, it's producing red blood cells, white blood cells, and platelets. Now imagine someone converts half the factory into a warehouse filled with junk. The machines still exist, but there's no room to run them. That's myelodysplastic anemia. Because the marrow is under stress and overcrowded, blood cell production becomes chaotic. On peripheral smear, you may see normocytic anemia, leukoerythroblastic picture, such as immature red blood cells and immature white blood cells. You may see teardrop-shaped red blood cells, which are known as dacrocytes. These teardrop cells happen because red blood cells are literally being squeezed out of a fibrotic marrow space. They're distorted as they exit, like Play-Doh forced through a crack. This anemia is often diagnosed on bone marrow biopsy, not just CBC. Your tissue processing, decalcification, section quality, and staining directly affect identification of tumor infiltration, visualization of fibrosis, and recognition of residual hematopoiesis. This is a prime example of where histology is not supportive, it's diagnostic. As marrow function declines, red blood cell production fails, which ends in anemia. White blood cell production fails, which increases our infection risk. Platelet production fails, which increases our bleeding risk. Patients often develop pancytopenia, fatigue, weakness, and shortness of breath. But the root cause isn't nutritional, it's structural. So key takeaways: bone marrow is physically replaced. The hematopoiesis is displaced, not defective. It's most commonly due to metastatic cancer. You might see teardrop red blood cells, which is a major clue. Diagnosis relies heavily on biopsy evaluation. In worthless but memorable knowledge, myelophytesis literally means marrow being worn away or displaced, which is exactly what's happening. The marrow doesn't fail, it gets crowded out. This one is important and very different from the anemias we've talked about so far, because aplastic anemia is not just a red blood cell problem, it's a bone marrow failure problem. In anaplastic anemia, the bone marrow fails to produce all blood cell lines. That includes red blood cells, white blood cells, and platelets. So instead of isolated anemia, patients develop pancytopenia, so low everything. Let's compare. Iron deficiency anemia, remember, marrow wants to work but lacks material. Chronic disease anemia, we have marrow is suppressed by inflammation. Myelocystic anemia, the marrow is crowded out, right? But in aplastic anemia, the marrow itself is non-functional. The factory is still standing, but the lights are off and no one is clocked in. Take a look at the images on this slide. Image A, which is normal marrow. So you have dense cellularity, abundant hematopoietic precursors, a balanced fat to cell ratio. That is what healthy adult marrow should look like. Image B is aplastic marrow. So you have dramatic increase in fat spaces, very few hematopoietic cells, and you have hypocellular marrow. This marrow is described as empty, not fibrotic, not infiltrated, just absent. Aplastic anemia marrow is hypocellular, fatty, lacking precursors. So no malignant infiltration, no fibrosis replacing the cells. The cells simply aren't there. This diagnosis often hinges on proper decalcification, excellent section thickness, preservation of cellular detail, and accurate fat to cell assessment. If the section is crushed or over-decalcified, it can falsely appear hypocellular. So yes, your processing matters here a lot. Because all cell lines are affected, decreased red blood cells result in fatigue, pallor, and shortness of breath. A decrease in white blood cells will see recurrent infections, and then a decrease in platelets will have bruising and bleeding. Patients often present with weakness, fever, petechiae, and nosebleeds, and also infections that won't resolve. Causes of aplastic anemia may be idiopathic, which seems to be the most common, autoimmune-mediated stem cells destruction, and drug-induced, as well as chemical exposure, so benzene, things like that. Also, viral infections and radiation are thrown in there as well. So there is a pure red cell aplasia, which is a variant, right? So this is a related but important distinction. In pure red blood cell aplasia, only erythroid precursors are affected. White blood cells and platelets remain normal. So it's most commonly associated with a parvo B19 infection, parvovirus B19 infection. Parvovirus selectively infects erythroid precursors, which is rude behavior for a virus, honestly. If bone marrow is a garden, myeloplastic anemia is the weeds taking over, iron deficiency is there's no fertilizer, and aplastic anemia is the soil is still there, but nothing is growing, just fat and silence. So key diagnostic hallmarks we'd see is pancytopenia on a CBC, hypocellular fatty marrow on biopsy, absence of fibrosis or tumor, and no effective compensation by marrow. Some worthless but useful knowledge. Normal adult marrow cellularity is roughly 100% minus the patient's age. plus or minus 10%. So a 40-year-old should have approximately 60% cellular marrow. Aplastic anemia patients may have 5 to 10% cellularity. That's not subtle. So big picture takeaway from this slide is primary bone marrow failure. It affects all blood cell lines. It produces pancytopenia. The marrow becomes hypocellular and fatty, and it's distinguished from infiltration and fibrosis by absence of slides. Diagnosis relies heavily on the bone marrow biopsy. All right, after talking about not enough red blood cells for many slides, we now swing hard in the opposite direction. Welcome to polycythemia, where the body says, you know what we need? More red cells. Lots more. Polycythemia is an overproduction of red blood cells, leading to increased hematocrit, increased blood viscosity, sluggish blood flow, and increased risk of clotting. Basically, the blood goes from nice and fluid to tomato juice trying to move through a coffee straw. Red blood cells are great. Too many red blood cells? Not so great. Thicker blood means slower circulation, increased shear stress, and that means you're at a higher risk for DVTs, pulmonary emboli, stroke, and even myocardial infarction, which is why that image of venous clotting on the side is very important. It's not just decorative. Okay? There are different types of polycythemia. So we have primary polycythemia, polycythemia vera, and this is the big one. It's a bone marrow malignancy classified as myeloproliferative neoplasm. It's caused by uncontrolled proliferation of red blood cells, precursors, and the marrow is not responding to oxygen needs. It's responding to mutations that say keep dividing. Most cases are associated with a JAK2 mutation, which essentially disables the normal brakes on erythropoiesis. In polycythemia vera, bone marrow shows hypercellular marrow, increased erythroprecursors, and it's often increased megakaryocytes as well as reduced fat spaces. This marrow is crowded, very different from the fatty emptiness we just saw with aplastic anemia. Important concept is that polycythemia vera is EPO independent, meaning red blood cells keep being produced even when erythropoietin levels are low. The marrow has gone rogue. And then secondary polycythemia, this one is much more logical. Here, red blood cell production increases because the body senses low oxygen or hypoxia. So the kidneys increase erythropoietin, which stimulates the marrow appropriately. This is a normal physiological response, just happening chronically. So common causes of secondary polycythemia would be chronic lung disease, such as COPD or emphysema, cyanotic congenital heart disease, chronic hypoxia, or even living at high altitude. If you live in Denver long enough, your marrow will absolutely notice. In secondary polycythemia, marrow is hypercellular, increased erythroid lineage, but regulation is still intact. Once oxygen levels normalize, red blood cell production can slow down, unlike polycythemia vera, which does not care. Patients with polycythemia may present with ruddy or flushed complexion, headaches, dizziness, visual disturbances, or pruritus after hot showers. Why itching? Because increased basophils and mast cells actively release histamine. Your blood is literally too spicy. So lab findings, we'd see elevated hemoglobin, elevated hematocrit, increased red blood cell count, and thick, viscous blood, sometimes even increased platelets as well. This combination is why clot risk skyrockets. Worthless but entertaining knowledge, polycythemia vera was once treated primarily by therapeutic bloodletting. Yes, basically medically approved vampire behavior. And honestly, it still works. So big picture takeaway, polycythemia is an overproduction of red blood cells, increased blood viscosity. It raises risk for thrombosis. There are two major categories, primary, which is bone marrow malignancy, such as polycythemia vera, and then there's secondary, which is an appropriate response to hypoxia. Histology shows hypercellular marrow with expanded erythroid lineage. Complete opposite appearance from aplastic anemia. If anemia is not enough cars on the highway, polycythemia is rush hour traffic with no exits. Everything slows, accidents happen, and nothing flows smoothly. All right, now that we've wrapped up red blood cell disorders, where the main question was how many red cells do we have and do they work, we're shifting gears into white blood cells. Think of this section as moving from oxygen delivery to immune defense. Different cells, different jobs, different pathology patterns. White blood cell disorders generally fall into two categories: increased white blood cell count and decreased white blood cell count. And just like with red blood cells, the number alone isn't the whole story. It's which cell line is changing and why. Increased white blood cell count. So when white blood cells go up, we call it leukocytosis. And the specific name depends on which cell type is elevated. So granulocytosis, this usually means an increase in neutrophils, which is the most common, and sometimes fans. It's most often associated with acute inflammation, bacterial infection, tissue necrosis, and stress response. On a peripheral smear, you may see increased segmented neutrophils, a possible left shift, and some band forms. You may also see toxic granulation and severe inflammation. This is the classic bacterial infection smear. Neutrophils are the ER nurses of the immune world, first on scene, loud, messy, and very effective. Then there's lymphocytosis and monocytosis. These are more commonly associated with chronic inflammation, viral infections, and long-standing immune stimulation. Lymphocytosis is often linked to viral infections and some chronic immune responses. So smear findings may include increased small lymphocytes and reactive atypical lymphocytes with abundant cytoplasm. Monocytosis increases when the body needs cleanup, debris removal, or chronic inflammation management. These are the macrophage precursors, the professional recyclers. Macrophages are basically the hoarders of the immune system. If there's old hemoglobin, iron, lipid, or cellular debris laying around, they collect it, which is why they show up everywhere in chronic disease. Then there's eosinophilia. Eosinophils increase in parasitic infections, in some allergic conditions, as well as asthma, drug reactions. So the smear appearance, eosinophils are easy to spot. They have a bilobed nucleus and that bright red-orange granules. So they're basically screaming, I am not subtle. Those granules contain major basic protein. It's designed to damage parasite membranes. Great for worms, not great for surrounding tissue. Now we move to the other side of the table when white blood cells decrease. We're talking about leukopenia, again characterized by cell line. So neutropenia and lymphopenia, these may be caused by certain viral infections, chemotherapy, bone marrow suppression, or even autoimmune destruction. Neutropenia is especially dangerous because no neutrophils equals no early inflammatory response. Patients can be very sick without obvious signs of infection. Peripheral smears may show markedly reduced neutrophils, normal appearing red blood cells, and an overall low cellularity. The smear looks quiet, which is actually very concerning. Then there's hypersplenism. Remember this from earlier? An enlarged overactive spleen can sequester red blood cells, platelets, and white blood cells, leading to pancytopenia or selective leukopenia. The spleen becomes a little too enthusiastic at its filtering job. Then we have anemia, associated white blood cell decreases. So both myelodysplastic anemia and anaplastic anemia can reduce white blood cell counts because the marrow itself is compromised. If the factory is damaged, every product line suffers, not just red cells. White blood cell disorders are rarely random. They usually reflect infection type, duration of inflammation, bone marrow health, immune system activity, and splenic function. Neutrophils are the emergency responders, lymphocytes are the long-term planners, the monocytes macrophages are the cleanup crew, the eosinophils are the parasite control, and the basophils are the allergy drama department. If one group suddenly spikes or disappears, something specific is going on. Some worthless but helpful knowledge: you can often guess the type of inflammation just by the differential. So increased neutrophils would be acute bacterial, increased lymphocytes, we're looking at viral, increased monocytes, we're looking at chronic, increased eosinophils is parasites or allergy. Your CBC differential is basically a clinical clue sheet. All right, we've talked red blood cells and white blood cells. So it's time to bring in the smallest but most dramatic blood component, and that is platelets. Platelets may be tiny cell fragments, but when they misbehave, things escalate very quickly. Think of platelets as the emergency patch kit for your vascular system. Their entire job is to stop bleeding, but too few or too many can both be dangerous. Platelet disorders fall into two broad buckets: thrombocytopenia, which is too few platelets, and thrombocytosis, which is too many platelets. And interestingly, low platelets are far more common than high platelets. So thrombocytopenia, again, decreased platelets, right? This is one you'll see most often clinically. Platelet counts drop because of one or more of the following: increased platelet destruction, so platelets are being made, they just don't survive long. Common mechanisms include platelet antibodies, so immune-mediated destruction. The spleen flags them as abnormal and removes them. This is essentially the platelet version of autoimmune hemolytic anemia. In peripheral smear, you may see very few platelets, sometimes large or giant platelets. This is the marrow trying to compensate. Otherwise, fairly normal red blood cells and white blood cells. Remember, platelets are cytoplasmic fragments of megakaryocytes, so when producing ramps up quickly, they're often oversized. Cause number 2 would be increased platelet utilization. Platelets are being consumed faster than they can be replaced. Most commonly seen in coagulation disorders and disseminated intravascular coagulation, or DIC, or massive clot formation. Here the body is basically saying, patch everything, everywhere, immediately, which does not end well. Cause number 3 is decreased platelet production. So the bone marrow simply can't keep up. Causes include aplastic anemia, myelocytic anemia, chemotherapy, the bone marrow suppression or replacement. If megakaryocytes aren't being produced, platelets never enter circulation. And then cause number 4 is hypersplenism. Yes, again. Our overachieving spleen returns. An enlarged spleen can sequester red blood cells, white blood cells, and platelets. This is one of the most common causes of mild to moderate thrombocytopenia. Platelets aren't gone, they're just stuck in splenic timeout. Some clinical consequences: so low platelets lead to petechiae, purpura, easy bruising, prolonged bleeding, and mucosal hemorrhage. Important distinction: platelet disorders cause bleeding, not clotting. If someone is bruising everywhere but their PT and PTT are normal, think platelets. Then we talk about thrombocytosis, which is increased platelets. This is a less common side of the spectrum. Thrombocytosis means elevated platelet count. This occurs in two main settings. We have reactive or secondary thrombocytosis, which is very common and usually temporary. It's seen with inflammation, infection, trauma, surgery, and iron deficiency anemia. Inflammation stimulates cytokines, which increases platelet production. Then there's primary thrombocytosis. It's much less common and it occurs with myeloproliferative disorders or bone marrow neoplasms or abnormal megakaryocyte proliferation. These platelets are often increased in number and decreased in function, which means patients can paradoxically have clotting and bleeding because dysfunctional platelets are chaotic little gremlins. Peripheral smears may show increased platelet numbers, platelet clumping, or enlarged or bizarre platelet forms. In bone marrow biopsies, we'd see markedly increased megakaryocytes, clustering instead of normal spacing. That clustering pattern is a big red flag for marrow pathology. Fun but useful knowledge, platelets only live 7 to 10 days. That's it. So platelet disorders can change rapidly, much faster than red blood cell disorders, which unfold over weeks. That is why platelet counts can swing dramatically in hospitalized patients. Big takeaway, platelet disorders are all about balance. So too few, we get hemorrhage, too many, and we get thrombosis. They are dysfunctional and that result in chaos. From a histology standpoint, your clues come from platelet number, platelet size, marrow megakaryocytes, associated red blood cell and white blood cell findings. Everything does tie together. Right, next, we're going to talk about one of the most commonly tested platelet disorders and one you will absolutely hear about in both clinical and lab settings. And that's idiopathic thrombocytopenic purpura, or ITP. And yes, the name already tells us half the story. Idiopathic means we don't know exactly why. Thrombocytopenic means low platelet count. And purpura is bleeding into skin and mucosa. So right out of the gate, we know ITP is unexplained immune-mediated platelet destruction. There's no bone marrow failure, no leukemia, and no clotting disorder. Just platelets being unfairly targeted. In ITP, the body forms autoantibodies against platelets. Platelets become antibody-coated. The spleen identifies them as abnormal, and then macrophage removes and destroys them. This is classic immune-mediated peripheral destruction, not decreased production. Okay? In ITP, the bone marrow is normal or hypercellular. Megakaryocytes are increased. Why? Because the marrow is desperately trying to compensate. I'm making platelets, you just keep destroying them. So if you see decreased platelets in blood, increased megakaryocytes in marrow, think peripheral destruction, not marrow failure. Even though it's labeled idiopathic, we do have strong associations. So some common triggers include drug-induced immune thrombocytopenia. This arises from heparin. It's famous for this. Antibiotics and certain anticonvulsants. And then there's post-infectious ITP in children. This often follows viral infections, and it's usually acute and self-limited. Kids often recover completely. Adults, unfortunately, tend to develop chronic ITP. And because platelets are low, symptoms are bleeding related. So petechiae, which are tiny pinpoint hemorrhages, purpura, easy bruising, mucosal bleeding, epistasis, and menorrhagia. Platelet disorders cause surface bleeding, not deep muscle bleeding. Okay? That distinction matters clinically. On smear, you'll typically see markedly decreased platelet number. Some platelets may appear large or giant. Red blood cells and white blood cells usually appear normal. Those giant platelets are young platelets. The marrow is working overtime. Treatment is aimed at stopping destruction, not boosting production. So common approaches include, the first one would be corticosteroids. So suppress the immune response and reduce antibody formation. Second would be splenectomy. So removes the primary site of platelet destruction. Often dramatically improves platelet count. This works because no spleen equals nowhere for macrophages to destroy platelets. And third, platelet transfusion. This is used only during active bleeding. Transfused platelets are often rapidly destroyed. So it's temporary support, not long-term therapy. Worthless but fun knowledge, ITP used to be called idiopathic thrombocytopenic purpura. Many sources now use immune thrombocytic purpura. Same acronym, same disease, slightly less shrugging by medicine. So if you see isolated thrombocytopenia, normal red blood cells, normal white blood cells, increased megakaryocytes, your brain should immediately whisper, this smells like ITP. Okay? Take-home message here is ITP is an immune disorder. It causes isolated thrombocytopenia with normal marrow production and increased peripheral destruction. From a histology standpoint, the key is remembering low platelets does not always mean bone marrow failure. Sometimes the marrow is working beautifully, the immune system is just being rude. This slide is a reminder that the hematopoietic system does not exist in a vacuum. When infection shows up, the bone marrow, spleen, lymph nodes, and circulating blood cells all respond, sometimes dramatically. Think of it as the immune system calling an emergency staff meeting. Infections often cause secondary hyperplasia affecting the hematopoietic system. So translation, the bone marrow ramps up production, lymphoid tissues enlarge, certain cell lines expand or shrink, and the peripheral blood smears start looking spicy. Not because the marrow is diseased, but because it's reacting. Let's start with malaria, which is the histology superstar on a slide, right? So malaria is caused by the protozoan parasite, so Plasmodium. The parasite lives inside red blood cells. Yes, actually inside them. Red blood cells become parasite hotels, free breakfast included, and checkout not optional, okay? On a peripheral smear, you may see ring forms inside red blood cells, multiple parasites in a single red blood cell. The red blood cell rupture during parasite release. This leads to hemolytic anemia, fever cycles, and splenomegalia. The spleen works overtime trying to clear infected red blood cells. Malaria is one of the few infectious diseases where diagnosis is literally made by staring at red blood cells. Then we have infectious mononucleosis, or the Epstein-Barr virus. So EBV primarily infects B lymphocytes. This leads to marked lymphoid hyperplasia, enlarged lymph nodes, and an enlarged spleen, which is why mono patients are told no contact sports, because a spleen the size of a grapefruit is not built for football. On a peripheral smear, you'll often see atypical lymphocytes, large cells with abundant cytoplasm, and cytoplasm that hugs surrounding red blood cells. These are reactive T cells, not malignant ones. It's an important distinction. So reactive does not mean leukemia. Okay? Then we have HIV, or the human immunodeficiency virus. HIV primarily affects the CD4 positive T lymphocytes. Over time, this causes progressive lymphocyte depletion, bone marrow suppression, increased susceptibility to infection. From a hematologic perspective, HIV may cause anemia, leukopenia, or thrombocytopenia. Basically, the entire CBC can fall apart. Granulomatous diseases. These are chronic inflammatory conditions characterized by granuloma formation. Granulomas are collections of activated macrophages, epithelioid cells, sometimes giant cells. They form when the immune system can't easily eliminate a pathogen. So examples include tuberculosis, systemic fungal infections, sarcoidosis. Granulomas may involve bone marrow, spleen, or lymph nodes, which mean normal marrow space can be displaced. Hematopoiesis may become impaired. If granulomas invade marrow, you may see decreased red blood cell production, cytopenias may develop, the marrow architecture becomes distorted. This is not a primary marrow disease, it's secondary involvement. Infections can cause reactive leukocytosis, lymphocytosis, or lymphopenia, and secondary anemia, or splenic enlargement, and even bone marrow hyperplasia. So when you see abnormal counts, always ask, is this a primary hematologic disorder, or is the immune system reacting to something else? Some worthless but excellent knowledge: malaria parasites digest hemoglobin and leave behind a pigment called hemozoin. Okay? That dark brown granular pigment can sometimes be seen microscopically. Basically, that's parasite poop. You're welcome. You can see that on the image there to the right. Key takeaway: infections don't just make people sick, they reshape the hematopoietic system. They can invade red blood cells directly, infect lymphocytes, trigger massive immune hyperplasia, and displace marrow with inflammation. From a histology standpoint, infections teach us one critical lesson: abnormal blood findings are not always cancer. Sometimes they're just the immune system doing its job very loudly. To this point, we've talked about reactive processes, nutritional deficiencies, infections, the bone marrow being tired, stressed, or overworked. Now we cross an important line. This slide involves neoplastic disease, meaning the problem is no longer regulation. The problem is clonal cell growth. In other words, the marrow has lost its off switch. A neoplasm is a clonal proliferation of cells that grows independently of normal control mechanisms. So unlike infection or inflammation where the marrow can calm back down, neoplastic cells do not clock out. They just keep showing up to work uninvited. You have myeloproliferative disorders, or MPDs. These are cancers of the bone marrow. They are involving myeloid stem cells, and that includes cells that normally become red blood cells, granulocytes, monocytes, or platelets. So instead of one lineage misbehaving, the stem cell itself is abnormal. In myeloproliferative disorders, bone marrow is hypercellular. One or more cell lines are massively increased, and the cells often appear mature, not blasts, or at least early on. That's important. These are not leukemias full of baby cells yet. These are too many adult cells. Think not immature chaos, but organized overproduction. Okay? Imagine a factory. Normal marrow results in regulated assembly line. Infection is overtime shift. Nutritional deficiency is missing supplies. Myeloproliferative disorder, well, the manager is gone and the machines won't shut off. Cells keep getting produced even when the body says, we're good, thanks. Across most myeloproliferative disorders, you'll see hypercellular marrow, increased circulating blood cells, splenomegaly, which is a huge theme here, and risk of thrombosis or hemorrhage. Why splenomegaly? Well, because the spleen becomes a filtration backup system, a graveyard for excess cells, and sometimes an extramedullary hematopoiesis site. The spleen basically says, fine, I'll make blood too. From a tissue standpoint, these disorders show up as dense marrow cellularity, reduced fat spaces, increased megakaryocytes, and abnormal architecture. And later on, marrow fibrosis and burned out marrow, as well as shifts of hematopoiesis to liver and spleen. So yes, this absolutely shows up in bone marrow biopsies. Important distinction is that myeloproliferative disorders are not reactive, not nutritional, not infectious. They are true malignancies of the bone marrow. But, and this is key, they often behave slowly and chronically. Patients may live many years with them, okay? Worthless but useful knowledge, most myeloproliferative disorders are associated with the JAK2 mutations. This mutation basically tells cells grow, divide, and ignore instructions. It's like permanently taping down the gas pedal. This slide is your transition point. We're moving from disorders of production and destruction into disorders of uncontrolled proliferation. From here forward, the marrow isn't responding incorrectly, it's genetically programmed incorrectly. So bottom line for histology students, when you see extremely cellular marrow, excess of one lineage, an enlarged spleen, abnormal megakaryocytes, and persistent elevated counts, you should start thinking, this isn't reactive. This is probably neoplastic. Now we're narrowing our focus. Instead of the entire bone marrow going rogue, like in myeloproliferative disorders, this slide is about malignancies of white blood cells specifically. So think, white blood cells gone bad. And there are two major categories you need to understand. The first one is leukemia, and the second one is lymphoma. They sound similar, they involve similar cells, but they behave very differently, especially from a histology standpoint. So let's talk about leukemia. Leukemia is defined by widespread infiltration of bone marrow by malignant white blood cells. The key word here is widespread. This is not a localized mass. This is a marrow takeover. In leukemia, malignant cells are found in the bone marrow and in the circulating blood, often in lymphoid organs as well. So if you're looking at peripheral blood smear, bone marrow aspirate, core biopsy, leukemia shows up everywhere. Under the microscope, you may see hypercellular marrow, crowding of normal hemopoietic cells, replacement of fat spaces, and sheets of abnormal white cells. As leukemia progresses, normal red blood cell production drops, which results in anemia. Normal platelets drop, which results in bleeding. Normal white blood cell function drops, which gives us infection. So basically, the marrow is full, but it's full of the wrong tenants. Okay? Leukemias are classified by two things: the type of white cell involved, so myeloid or lymphoid, the speed of the disease, acute or chronic. So you'll see names like acute lymphocytic leukemia, or ALL. This is most common childhood leukemia, or chronic myeloid leukemia, CML. This is classic myeloproliferative type leukemia. Okay. Then you'll see acute versus chronic. So acute leukemia, you'll have lots of blasts and immature cells, fast progression, and very sick patients. Chronic leukemia, you'll have more mature appearing cells. It's a slower course, and it's often discovered incidentally on CBC. Same disease family, just very different microscope appearance. Okay. Leukemia diagnosis is made using peripheral blood smears, a bone marrow aspirate, a bone marrow biopsy, which is why this lives squarely in pathology. Histotechs absolutely touch these cases. Okay. Now, let's move on to lymphoma. Lymphoma is very different. Lymphoma is a malignancy of lymphoid cells that forms discrete masses. Key phrase, discrete masses. Okay. Where does lymphoma live? Well, it primarily lives in lymph nodes, the spleen, the tonsils, or extranodal tissues. Okay. Importantly, not initially found in circulating blood. That's your biggest clue. Think of it this way: leukemia equals spilled paint everywhere, including the bloodstream. Lymphoma equals paint blobs, localized lumps in lymphoid tissue. One spreads diffusely, one grows in organized clumps. In lymphoma, you'll see effaced lymph node architecture, sheets of atypical lymphocytes, and loss of normal follicles or sinuses. You are not looking at marrow first, you're looking at tissue. Unlike leukemia, lymphoma is not labeled acute or chronic. Instead, it is grouped as Hodgkin's lymphoma or non-Hodgkin's lymphoma. This classification is based on cell morphology, immunophenotype, architectural patterns, and yes, Reed-Sternberg cells will make their dramatic appearance. Let's put it simple. Different diseases, different slides, different stains, different workflows, okay? Fun fact, some lymphomas can eventually spill over into the blood. When that happens, they start behaving like leukemia because pathology, again, loves chaos, okay? So this slide is teaching you one critical concept. Where the malignant cells live defines the disease. In the blood and marrow, it's leukemia. In lymphoid tissues, it's lymphoma. Same immune system, different neighborhoods. So histotech's mindset to remember is when you hear bone marrow biopsy, peripheral smear, pancytopenia, think leukemia. When you hear enlarged lymph node, mass lesion, tissue architecture loss, think lymphoma. Now that we understand what leukemia is, let's talk about the two major lymphoid leukemias you'll see in both lectures and across the labs. So acute lymphoid leukemia, which is ALL, and chronic lymphoid leukemia, which is CLL. Okay, same cell lineage, very different behavior. Think of this slide as fast and furious versus slow and sneaky. So ALL is defined as malignant proliferation of an immature lymphocyte precursors. The key word here is immature. Okay, these cells are blasts. They never learned how to do their job. The cell types that are involved is usually B cell precursors and rarely T cell precursors. So under the microscope, you're not seeing functional lymphocytes. You're seeing arrested development, like teenagers who never graduated but still moved into the bone marrow basement. Okay. So who gets ALL? Well, most common malignancy in children. This is why pediatric hemopathology spends so much time on ALL. In ALL, you'll see large numbers of lymphoblasts, high nuclear to cytoplasmic ratio, fine chromatin, inconspicuous nuclei, nucleoli, scant basophilic cytoplasm. In the marrow, blasts crowd out normal hematopoiesis, fat spaces disappear, and everything starts looking very blue. In the blood, circulating blasts appear early. So our clinical behavior, we have abrupt onset, rapid progression, and the patient often presents very ill. Why? Because blasts don't carry oxygen, they don't fight infection, and they don't help with clotting. They're just there, taking up space. So as a histotech, if you see marrow packed with uniform blue cells, very little differentiation, and few mature elements, think acute leukemia until proven otherwise. Okay, now let's shift gears. Chronic lymphoid leukemia, or CLL. It's almost the opposite of ALL. Instead of immature cells, CLL involves many mature appearing lymphocytes in the blood. Important word, mature appearing. They look normal, but they aren't functioning normally. What makes CLL unique is that there's a very high lymphocyte count, the cells appear small and well differentiated, and it's often discovered incidentally, meaning patients feel fine, CBC says otherwise. Okay? So, classic scenario, someone gets routine blood work for an annual physical or insurance labs or pre-op testing, and the report comes back with marked lymphocytosis. Surprise. Peripheral smear often shows normal small lymphocytes, condensed chromatin, scant cytoplasm, and smudge cells from fragile lymphocytes. Smudge cells are not diagnostic alone, but they're very suggestive. Okay? CLL is slow, very slow. Patients may live 10 to 20 years. Many never require immediate treatment. The average untreated survival is approximately 10 years. So while it's malignant, it behaves more like a chronic condition. Okay? So ALL would be like the kindergarten classroom with no teacher. Chaos, fast, loud, everything breaks quickly. CLL is kind of like the retirement community that quietly takes over the town. Slow, polite, still a problem. Both are malignant, just very different personalities. Okay? Why this matters in histology is because the appearance tells the story. You're not memorizing leukemia types for fun. You're learning how to recognize patterns. Blasts versus mature cells. Diffuse blue marrow versus subtle. Lymphocytosis. Abrupt failure versus long-term accumulation. Your microscope gives you the clues. Okay? So big takeaway, ALL is immature cells plus fast disease. CLL is mature cells plus slow disease. Same lineage, different behavior, completely different slides. Okay, this is the money slide. This is where we stop talking in theory and start talking in cells on glass. Same diagnostic category, same lineage, completely different appearance. Okay, the left image is acute lymphoid leukemia, ALL. Take a look at this smear. What should immediately jump out at you? Big, purple, immature, everywhere. These are lymphoblasts. Okay, you'll notice large cells, very high nuclear to cytoplasmic ratio, fine open chromatin, invisible nucleoli, and scant basophilic cytoplasm. Translation, these cells never finished growing up. They're stuck in lymphocyte kindergarten forever. Why this matters? Blasts, they don't carry oxygen, they don't fight infection, and they don't participate in immunity. They just take up real estate. So the bone marrow becomes overcrowded with useless cells, which leads to anemia, thrombocytopenia, and neutropenia. Basically, everything good disappears. Okay? So as a histotechnologist, when you see a field dominated by uniform blasts, very little variation, very little maturation, your brain should immediately say acute leukemia until proven otherwise. On the right image, we have chronic lymphoid leukemia, CLL. Notice the difference? These cells are smaller, they're more condensed, and they're darker chromatin, right? So much more normal looking. And that's what makes CLL so sneaky. You'll see numerous small mature lymphocytes, clumped soccer ball chromatin, minimal cytoplasm, and occasional smudge cells. That arrow is pointing to a classic lymphocyte. Nothing dramatic, nothing flashy, which is exactly why CLL often flies under the radar. So an important distinction: in CLL, the cells look mature, but they are functionally incompetent. So the immune system looks crowded, but performs poorly. Quantity does not equal quality, okay? Think of it this way: ALL, immature cells, large blasts, rapid onset, kids more commonly affected, looks chaotic under the scope. CLL, mature appearing cells, small lymphocytes, slow progression, older adults, and looks deceptively boring, okay? ALL is like a daycare where no one ever grows up. Loud, fast, completely dysfunctional. CLL is an office full of employees who show up every day, but no one actually works. Both are malignant, just very different personalities. And worthless but fun knowledge: the classic smudge cell in CLL isn't a real cell type. It happens because CLL lymphocytes are fragile. They rupture during slide preparation. So yes, sometimes the diagnosis starts because the cells literally fall apart. And why this slide matters for histotechnology is because leukemia diagnosis doesn't start with genetics. It starts with a well-made blood smear, your stain quality, your cell preservation, your technique. These images are exactly what hematopathologists rely on first. So big picture takeaway again: ALL is immature blasts that dominate, and CLL is mature lymphocytes that accumulate. Both are leukemia. Both look completely different under the microscope. And now you can actually see it. We move from leukemia floating in blood to lymphoma building real estate in tissue. This is the key mental shift. Leukemia equals marrow and blood. Lymphoma is solid lymphoid organs. So lymph nodes, spleen, tonsils, malt tissue. If it forms a mass, think lymphoma. There are two major types. We have Hodgkin's lymphoma, or HL. This one earns its diagnosis by a celebrity cell, and that is the Reed-Sternberg cell. These are very large, binucleated or multinucleated, and they have prominent nucleoli, and they also have a classic owl eye appearance. If you see Reed-Sternberg cells, it's Hodgkin's lymphoma. No debate, okay? Despite what the slide says, Reed-Sternberg cells are typically identified on lymph node biopsy, not routine peripheral blood smear. This is why tissue architecture matters so much, okay? Next, we have non-Hodgkin's lymphoma, or NHL. This is basically all lymphomas that are not Hodgkin's, which is a lot of them. So NHLs, they lack the Reed-Sternberg cells. They can arise from B cells, T cells, or NK cells. They have a wide variation in behavior. Some are slow and indolent. Some are aggressive and terrified. Same category, very different personalities, okay? Pathology doesn't stop at Hodgkin's versus non-Hodgkin's, though. We go full histology detective mode. Classification includes cell size. Is it small versus large lymphocytes? Immunologic markers, B cell, CD20, T cell, CD3, or neither. Histologic pattern: is it follicular or diffuse? Cellular structure details, such as the nuclear shape, the chromatin pattern, or the mitotic activity. This is where histotechnologists really shine. With the follicular pattern, think fake lymph node architecture, okay? You'll see microscopic lymphoid follicles, organized nodular appearance, slower growing disease, generally better prognosis. These tumors look polite. They follow the rules mostly. A diffuse pattern. Now this one does not care about your rules. Diffuse lymphomas destroy normal lymph node architecture. No follicles. They are sheets of malignant cells and rapid growth, and they can be fatal quickly if untreated. If follicles are gone and everything looks chaotic, diffuse lymphoma until proven otherwise. Because lymphocytes are immune cells, lymphoma patients often develop recurrent infections, autoimmune disorders, increased risk for additional malignancies. It's like the immune system loses its quality control department, okay? Unlike leukemia, lymphoma diagnoses require lymphoid organ biopsy. Why? Because architecture matters. Blood alone doesn't show follicles, diffuse patterns, or structure disruption. This is tissue diagnosis territory, not smear-only pathology. So examples you'll hear constantly with diffuse large B-cell lymphoma would be aggressive, most common non-Hodgkin's lymphoma. It's treatable but fast-moving. Then there's follicular small B-cell lymphoma. This is slower, chronic, and often relapsing. Again, same lineage, completely different outcomes. Okay. Think of lymphomas like neighborhoods. Follicular lymphoma is the planned community. It's organized. It has HOA vibes. Diffuse lymphoma is everything bulldozed, no structure, absolute chaos. Histology tells that story instantly. Okay. Worthless but useful knowledge, Reed Sternberg cells are actually B cells that lost their normal B cell markers and forgot who they were supposed to be. So pathology identity crisis at its finest. So big picture takeaway, lymphoma equals the solid lymphoid malignancy. Hodgkin's, you'd see Reed Sternberg cells present. Non-Hodgkin's means everything else, okay? Architecture matters, biopsy is essential, and histology guides prognosis and treatment. All right, this slide is where hematopathology stops being abstract and becomes very real very fast. Up to now, we've talked about cells, smears, microscopic patterns, and now we zoom out and look at what lymphoma actually does in the body. This is a gross specimen showing the aorta for anatomic reference. Massively enlarged lymph nodes surrounding it. These are not mildly reactive nodes. These are not soft, they're not tender, they're not infection related. These are neoplastic lymph nodes, okay? Normal lymph nodes are small, usually less than 1 centimeter. They're soft and mobile, discrete and separated. They have organized internal architecture. Malignant lymph nodes are enlarged, sometimes dramatically. They are firm or rubbery, and they're often matted together. They replace normal nodule architecture entirely. Histologically, those follicles and sinuses you learned about, well, they're gone, bulldozed. No zoning permits issued. Why they get so large is that lymphoma cells proliferate uncontrollably and they fail to undergo apoptosis. They also accumulate in lymphoid tissue and continue dividing without regulation. So instead of flowing in blood like leukemia, they stay put and expand outward. That's why lymphoma often presents as painless lymphoidenopathy, mediastinal masses, or abdominal or retroperitoneal lymph node enlargement. Okay? When these nodes are biopsied, histology typically shows effacement of normal architecture, replacement of sheets of malignant lymphocytes, either follicular pattern, which is organized nodules, or diffuse pattern, which is complete chaos. This gross enlargement correlates directly with what you see under the microscope. Why the aorta matters? The labeled aorta isn't just anatomy trivia. It tells us these lymph nodes are deep, often not palpable externally. So they're frequently discovered on CT scans, MRI, or PET imaging. Many lymphomas are found incidentally because these nodes can grow silently. Clinical impact, we'd see massive nodule enlargement can cause compression of blood vessels, obstruction of lymphatic flow, organ displacement, or pain or pressure symptoms. In the chest, this can mean shortness of breath, superior vena cava syndrome, cough. In the abdomen, it could be early satiety, bowel obstruction, and back pain, all from lymph nodes doing way too much. Think of lymph nodes like office buildings. Normal, a few employees, organized departments, functional workflow. Lymphoma, every cubicle cloned infinitely. No management, no exits. Fire hazard violations everywhere. Eventually, the building expands into the parking lot. Worthless but full knowledge, lymphomas often feel rubbery on physical exam. This texture is classic enough that clinicians still describe it in textbooks, even in the CT MRI era. Yes, pathology still uses adjectives like a wine tasting event. Okay? Key takeaway, lymphoma is a solid tumor of lymphoid tissue, causes massive lymph node enlargement. Nodes may surround major vessels and organs. Gross findings correlate directly with histologic pattern, and diagnosis requires tissue biopsy, not blood alone. Architecture loss is the hallmark feature. Okay, welcome to the lymphoma that pathology students both love and fear. not because it's complicated, but because it contains one of the most dramatic cells you will ever meet under the microscope. Meet the Reed-Sternberg cell. So big picture first, Hodgkin's lymphoma is a malignancy of B lymphocytes. Typically arises in a single lymph node. It spreads in a predictable, orderly pattern from one node to the next adjacent node. And important good news, it's curable in most cases, especially when diagnosed early. This makes Hodgkin's lymphoma very different from non-Hodgkin's lymphoma, which tends to spread more chaotically. Let's zoom in on that histology image. Reed-Sternberg cells are very large, often binucleated or multinucleated, and have prominent nucleoli. Classic appearance is owl eyes. Once you see them, you never unsee them. They look like they know secrets. Key histologic feature is they're derived from germinal cell center B cells. They're surrounded by reactive lymphocytes, plasma cells, eosinophils, fibroblasts. And a fun pathology twist, the Reed-Sternberg cells are actually rare in number. The massive lymph node enlargement is mostly from reactive inflammatory cells. So the tumor creates its own supportive fan club. Reed-Sternberg cells release cytokines that recruit inflammatory cells, suppress normal immune responses, cause lymph node enlargement, and produce systemic symptoms. This explains the classic B symptoms: fever, night sweats, weight loss. Not because of tumor bulk, but because of immune signaling chaos. Okay? The photo on the slide shows marked cervical lymphoidenopathy. This is one of the most common presentations. Painless, firm, slowly enlarging, and often noticed incidentally. Patients often say, "I didn't feel sick, my neck just kept getting bigger," which is never something you want to Google at 2 a.m. So unlike non-Hodgkin's lymphoma, Hodgkin's lymphoma spreads continuously, node to node to node. Predictable staging pattern. This predictable behavior is one reason it responds so well to radiation, chemotherapy, and treated therapies. Pathology behavior directly informs treatment success. So diagnosis of Hodgkin's lymphoma requires tissue biopsy, identification of Reed-Sternberg cells. Blood smears alone are not sufficient. If you don't see Reed-Sternberg cells, it's not Hodgkin's lymphoma. Pathologists do not negotiate on that point. Think of Hodgkin's lymphoma like a bad party host. Only a few actual troublemakers, which are the Reed-Sternberg cells, but they invite everyone from every department with no supervision. The house looks packed, the neighbors call the police, and the original host pretends innocence. Classic manipulation tactic. Some worthless but fantastic knowledge. The Reed-Sternberg cell was described in the late 1800s, long before immunohistochemistry, flow cytometry, or molecular testing. Pathologists diagnosed Hodgkin's lymphoma with glass slides, candlelight, and vibes. Honestly impressive. So key takeaway, Hodgkin's lymphoma is a B cell malignancy characterized by Reed-Sternberg cells, spreads slowly and predictably, and often presents as painless lymphoidenopathy. It is highly treatable and frequently curable. And diagnosis is histologic. No Reed-Sternberg cells, no Hodgkin's lymphoma. Now we move from lymphoma that plays by the rules to the one that absolutely does not. If Hodgkin's lymphoma is orderly and predictable, non-Hodgkin's lymphoma is chaos with a microscope slide. Non-Hodgkin's lymphoma represents a diverse group of lymphoid malignancies, derived from B cells most commonly, T cells, and natural killer cells, and unified mainly by one thing. They are not Hodgkin's lymphoma, so we'll see no Reed-Sternberg cells, none, not even one hiding in the corner. Unlike Hodgkin's lymphoma, NHL is more aggressive. It's usually more advanced at diagnosis. It does not spread in an orderly pattern. Instead of node, adjacent node to the next node, NHL tends to say, let's try everywhere at once. Non-Hodgkin's lymphoma spreads widely from the original site. It frequently involves multiple lymph nodes, bone marrow, the liver, the spleen, the GI tract, the skin, and the central nervous system. Fun and slightly terrifying fact, about 1/3 of NHL cases arise outside lymph nodes entirely. These are called extranoidal lymphomas. So sometimes the lymphoma isn't even lymph tissue. Pathology keeps us humble, okay? From a histology perspective, instead of one defining cell like the Reed-Sternberg, NHL is classified by cell size, so small, intermediate, large, cell type, B cell, T cell, NK cell, growth pattern, follicular or diffuse, mitotic rate, immunophenotype, so CD markers. Putting that into translation, it's histology plus immunohistochemistry is mandatory. You cannot eyeball NHL and guess correctly. Anyone who tells you otherwise is flat out lying. NHL often presents with multiple sites involved, with vague symptoms, without a single dramatic lymph node enlargement. Patients may have fatigue, mild anemia, recurrent infections, abdominal fullness, or GI symptoms. So by the time it's biopsied, disease is frequently already disseminated. If Hodgkin's lymphoma is one bad actor causing drama in a specific room, non-Hodgkin's lymphoma is a flash mob that appeared in 5 buildings simultaneously, and nobody knows who started it. Same family of cells, very different behavior. Why this matters clinically is because NHL is often aggressive, spreads widely early, frequently involves bone marrow. Patients may develop anemia, thrombocytopenia, and leukopenia, not because the cancer is in the blood initially, but because it replaces normal marrow. Histology tells the story before labs do again. So again, key takeaways for non-Hodgkin's lymphoma. We will see no Reed-Sternberg cells, often diffuse architecture effacement, variable cell size and appearance, and it requires biopsy, flow cytometry, IHC, and sometimes molecular studies. This is where histotechnologists shine. Your tissue quality matters enormously here. Worthless but useful knowledge, there are over 60 recognized subtypes of non-Hodgkin's lymphoma, which means nobody memorizes them all, everyone uses classification charts, and pathologists still argue about them. Science is so fun. Key takeaway, non-Hodgkin's lymphoma is more aggressive than Hodgkin's lymphoma. It's often advanced at diagnosis. It's frequently extranodal. It spreads unpredictably. It lacks Reed-Sternberg cells, and it requires detailed histologic and immunophenotypic analysis. So in short, if Hodgkin's lymphoma is organized crime, non-Hodgkin's lymphoma is random acts of violence. Pathology humor, but so accurate. This slide is where your eyes finally get to do some of the work, because this distinction is entirely architectural. Not cell shape, not nuclei, not mitotic figures. Architecture, architecture, architecture. So on this slide, you're seeing 3 different lymph node patterns. A is follicular non-Hodgkin's lymphoma, and B is normal lymph node for comparison, and C is diffuse NHL. Same tissue type, very different organization. Let's start with what good looks like. In a normal lymph node, you should see a capsule and cortex with follicles. You should see germinal centers and intervening sinuses. So clear organization. Think of it like a well-organized grocery store. Produce in one area, dairy in another, aisles clearly labeled, and everything has a place. Now look at panel A. You'll notice round lymphoid follicles, repetitive nodular pattern, the follicles packed tightly together. There is very little intervening space. At first glance, it almost looks normal, and that's exactly why follicular lymphoma can be sneaky. Key difference from normal follicles are the follicles are uniform in size, they lack normal polarization, and they often lack tangible body macrophages. Architecture is preserved, but abnormal. It's like a box of identical donuts. Real follicles vary. These do not. Okay? Clinical correlation is follicular NHL is typically lower grade, slower growing, indolent, better prognosis, but, and this is important, it can transform into diffuse large B-cell lymphoma, which is much more aggressive. Pathology never trusts quiet. Now look at the far right image, and honestly, it looks like chaos. You will notice no follicles, no nodules, no recognizable lymph node architecture. It's just a sheet of malignant lymphocytes. Everything is replaced. That is what we mean by diffuse growth pattern. Okay? Diffuse pattern equals architectural obliteration. Instead of organized follicles, cells grow in sheets. Normal structure is gone. The sinuses are gone. The cortex and medulla are indistinguishable. If follicular non-Hodgkin's lymphoma rearranges the furniture, diffuse non-Hodgkin's lymphoma bulldozes the entire building. So why this matters clinically? The follicular pattern is slower progression, often managed conservatively at first, and has a long survival. The diffuse pattern is aggressive, it has rapid growth, requires prompt chemotherapy, and is potentially curable if treated early. Same cell lineage, different architecture, very different outcomes. Okay? So if you see round nodules, think follicular. If you see sheets of cells, think diffuse. No normal lymph node landmarks is diffuse, and preserved nodular pattern is follicular. This distinction alone can determine treatment intensity. Some worthless but useful knowledge. Diffuse large B-cell lymphoma is the most common type of non-Hodgkin's lymphoma worldwide. It accounts for approximately 30 to 40% of cases and can arise de novo or from transferred follicular lymphoma. So follicular NHL is basically the calm before the storm in some patients. Now we're moving out of lymphocytes and into their highly specialized cousins, plasma cells. And when plasma cells go rogue, we get multiple myeloma. Multiple myeloma is a malignant neoplasm of plasma cells that arises in the bone marrow. It's characterized by uncontrolled plasma cell proliferation. Just remember, plasma cells are terminally differentiated B cells whose entire job is to make antibodies. In multiple myeloma, they don't just make antibodies, they make way too much of one bad one. So where does it start? In the bone marrow, especially vertebrae, ribs, skull, and the pelvis. Hence the name multiple myeloma. There's multiple marrow-based lesions. Radiology often describes these as punched out lytic bone lesions. What happens in the marrow? Well, the malignant plasma cells expand within marrow spaces, they crowd out normal hematopoiesis, they replace healthy plasma cells. This leads to decreased normal antibody production and increased abnormal monoclonal immunoglobulin. So patients paradoxically have too many antibodies, but very poor immune protection. Again, quantity does not equal quality. When you look at bone marrow biopsies or aspirates, you may see sheets of plasma cells, eccentric nuclei, clock-faced chromatin, and prominent nuclear HOF, which is the Golgi zone. Sometimes you'll also see Russell bodies, which are intracellular immunoglobulin, Mott cells, which are plasma cells stuffed with antibody, and basically plasma cells that ordered too much from Amazon and can't return it. So let's talk about monoclonal immunoglobulins. The malignant plasma cells produce excess immunoglobulins, or free light chains, so kappa or lambda. These can be detected in blood, as in an M protein spike on SPEP, or urine, so Bence-Jones proteins. Histotech side note, these light chains are what contribute heavily to renal disease. The classic way to remember myeloma symptoms is CRAB, C-R-A-B. C means hyperkalemia, R, renal failure, A, anemia, B, bone pain, lesions. Your slide highlights many of these. Bone pain, which is very common presenting symptom. Anemia, we have the marrow replacement. Infection, loss of normal antibodies. Amyloidosis, and renal failure. Why amyloidosis? Well, excess immunoglobulin light chains, they misfold, they deposit in tissue, they form amyloid. This can affect kidneys, heart, liver, and the tongue. Another reason pathology should respect plasma cells. They hold grudges. Cause? Short answer, it's unknown. But associations include older age, environmental exposures, and prior plasma cell dyscrasias, like MGUS. Multiple myeloma diagnosis typically involves bone marrow biopsy in serum protein electrophoresis, also called SPEP, S-P-E-P, or urine protein electrophoresis, which is UPEP, U-P-E-P. Imaging for bone lesions. Histology confirms the cellular player. Lab testing confirms what those cells are secreting. Teamwork makes the diagnosis work. So, key takeaway, multiple myeloma is a malignancy of plasma cells. It originates in the bone marrow, and it produces excess monoclonal immunoglobulin. Replaces normal marrow, and we get anemia and infection. Causes: bone destruction, renal failure, amyloid deposition. And from a histology standpoint, if you see too many plasma cells, always ask why. Worthless but fun knowledge, despite the name, multiple myeloma, it is almost always systemic at diagnosis. It rarely forms a single isolated mass and is one of the few cancers where bone destruction occurs without new bone formation. That's why X-rays look like Swiss cheese. Okay, we just covered a lot of hematologic pathology, so this slide is your official pause button. No new diseases here, just a moment to let your brain catch up before we move on. What should you be thinking about right now? When you look back at everything we've covered, ask yourself, can I tell the difference between reactive versus neoplastic processes? Do I understand where each disease starts, the bone marrow, the blood, or lymph node? Can I connect what I see on a slide to what's happening clinically? Because histology is never just what does it look like? It's always why does it look that way? So some guiding questions to consider. You don't need to answer these out loud, just think them through. Why does leukemia show abnormal cells in circulating blood, but lymphoma usually doesn't? Why does multiple myeloma cause bone pain? Why do plasma cell disorders affect the kidney? Why does follicular lymphoma have a better prognosis than diffuse lymphoma? And why do Reed-Sternberg cells matter so much? If you can answer even half of these, you're doing great. Just remember, when you're looking down the microscope, always ask, is this a problem of too many cells, too few cells, wrong cell type, or wrong location? Those 4 questions will solve about 90% of pathology. Worthless but helpful knowledge. Pathology is not memorization heavy if you understand patterns. Look at it like this. Leukemia, you have marrow plus blood. Lymphoma, solid lymphoid tissue. Myeloma, plasma cells behaving badly. Diffuse disease is a worse prognosis. Organized architecture is usually better behavior. Your eyes are learning patterns even when your brain feels tired. That's normal. So before we move on, if at any point you're thinking, these all sound the same, you're not wrong at first. But with repetition, these subtle differences become obvious. Just like distinguishing neutrophils versus eosinophils, or collagen versus muscle, artifact versus pathology. It clicks, I promise. Bottom line, this slide exists to say you're not behind, you're not expected to master this instantly, you're building pattern recognitions, and that's exactly how histotechnologists learn pathology.